Good evening, and welcome to Doctors on Call. Tonight, we're answering your questions on everything from Alzheimer's disease and chronic migraines to the treatment of strokes and other neurologic problems. I'm Dr. Ray Christensen from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School, Duluth, and I'm your host tonight. I'm pleased to welcome our panelists, Dr. Rachel Gordon, an internal medicine specialist at St. Luke's Internal Medicine Associates. This is Dr. Gordon that you're seeing now. Welcome, Dr.
Hi.
Gordon. Dr. Amy Greminger, a geriatric elder care specialist with Essentia Health and a faculty member at the medical school in Duluth, and Dr. Vikram Jadhav, a neurologist with Essentia Health. We'll be taking your questions at 218-788-2844 or toll-free 877-307-8762. Our medical students answering the phones tonight are Sylvia Fraser from Red Wing, Minnesota, Mickey Morgan from Sartell, Minnesota, and Jennifer Notch of Eden Valley, Minnesota. And now on to our program on stroke and other neurologic problems. Dr. Vic, I'm going to go to Vic because I know I'm not going to do well on your last name.
Not at all problem. That works well.
Tell us a little bit about yourself. You and I hadn't met till tonight, and I think you're fairly new to Duluth. So you want to tell us about your practice and what you do?
Sure. So after I actually graduated, did my residency at the University of Minnesota, then I moved to Cleveland to do my fellowship in stroke and cerebrovascular diseases, and now I'm a stroke neurologist at St. Mary's Duluth in Essentia Health. And our practice ranges from not only stroke, but any pathology that deals with the vessels of the brain and the spine. And we provide patient care to northern Minnesota patient population.
Well, thank you and welcome.
Thank you.
Dr. Greminger, you've been with us before. Do you want to tell us a little bit about what you do?
Yeah, I feel so lucky that in my day of clinic practice, when I'm not teaching at UMD, I get to see nursing home patients, and so there's certainly lots of neurologic things that go on in nursing home patients, and it's a wonderful patient population. Love seeing that population. I feel really lucky to be able to do that.
That's great. Dr. Gordon?
So I am a primary care internal medicine physician at St. Luke's, which means I take care of people in a wide range of medical conditions, from taking care of them right when they have their stroke in the hospital, as well as managing migraines as an outpatient, or taking care of them after they've had a stroke on an outpatient basis or in a nursing home.
Well, Dr. Gordon, I think I'd like to start with you this evening, and welcome to Duluth too.
Thank you.
You're new with us.
Yeah.
What is a transient ischemic attack or a TIA? And I'm told that's still an okay language to use.
Sure.
So do you want to talk to us and tell us what that is?
Sure. So TIA, and I've heard some people refer to them as mini strokes as well, but TIA, or transient ischemic attack, is what we like to call them. Really what that is it's a syndrome in which a patient has stroke-like symptoms. So they have developed weakness or numbness in an extremity or in a part of their body, something that would be consistent with a clinical picture like a stroke. However, as time goes on, that self-resolves. And the most important part is that if we were to look at the brain, either with imaging or with examining them over time, all of those deficits that they presented with go away and they're no longer left with those.
So then, Amy, would you carry that on to what is a stroke?
So a stroke is the same kind of idea in that there's some sort of insult to the brain. But instead of being something that's temporary, a stroke is something that causes more permanent deficit, or deficit that's able to be seen over time. And while sometimes with rehab and time, symptoms can certainly improve, when we do subsequent scans on the brain, we find that there's still damage that we can see, and the person is left with some permanent evidence that something happened there.
So Vic, I'm kind of moving down toward you as we talk about this. You're at that point. As I left really active practice in the emergency room, we were putting together the stroke network in Minnesota. And that's happened now. And you sit at the receiving end of strokes. The work that you do is to look at those strokes. What can you do to reverse or help that person who's having a stroke?
Well, the world of stroke care has made rapid advancements in the last couple of years. And we have had 7 to 8 clinical trials. These are randomized controlled clinical trials. So the best possible evidence that you can have, which have shown that you can do a lot for the stroke patients. First of all, we always knew that we had the clot busting medication that you can give to stroke patients. And here I'd like to clarify, we are talking about the majority of the strokes, 80% of them, which are the ischemic kind. What I mean by that is there is a clot or some sort of occlusion or stenosis of the blood vessel that is supplying blood to the brain. And if there is not enough blood supply to that part of the brain, then the brain starts lacking, starts getting decreased oxygenation and nutrients, so it starts having a stroke, and then the patient or the person starts having stroke-like symptoms. So we were giving clot-busting medication to patients who are having stroke-like symptoms within the first 4.5 hours from the time of symptom onset. But if the patient were to present after that time period, say up to like 6 to 8 hours, or if the patient was not eligible to get the clot-busting medication because they have had a recent surgery or they have a high risk for bleeding, in those patients, we can still go in with a catheter-based approach. So in that approach, you actually put a catheter through the groin or through the arm blood vessel, and you go up to the blood vessel in the neck or the brain where the clot is there, and you can actually capture that clot and take it out. So these trials had already shown that a couple years back. And people were already on the path to treating strokes from the time of onset, like 6 to 8 hours from the time of onset of symptoms. But now there is a recent trial that came out, and it's actually named DAWN trial. And in this trial, they were able to show that patients who had wake-up symptoms, unfortunately, we did not know what time the patient had a stroke because he was sleeping through it, and he woke up with the symptom. So in those cases, we can actually take the patient and do some specific imaging to look at what we call penumbra. So penumbra is the technical term which shows us how much of the brain is at the risk for having stroke but hasn't stroked out yet. So that is still a part of the brain that can be saved and that can be salvaged. So the idea is to do this kind of imaging and look at the salvageable part of the brain and protect it. And if we know that there is a significant chunk of brain that can be still salvaged, we can still use the catheter-based approach, go in through the groin and capture the clot and take it out, and patients have done significantly better.
All right, so now we've gotten through this. Let's go all the way back. And Dr. Gordon, what do you do with your practice to try to avoid this in the first place? And Amy, you may want to jump in on this too.
Yeah. That's a good question, and one that I think I get frequently from patients is, what can I do to decrease my chance of having a stroke? And a lot of the times when we talk about decreasing the chance of having a stroke, we also talk about decreasing the chance of having a heart attack. They can come together. So basic lifestyle changes would be keeping your weight down, not smoking or quitting smoking if you currently smoke. And then there are screening things that we do in the office. Most importantly is checking your blood pressure. That's probably one of the most important tenets of a basic annual physical exam, is just checking blood pressure. And if that's elevated, working on bringing it down. We also then tend to look at cholesterol as well on a screening basis, either every couple of years or more frequently if we've identified a problem, and then talk about starting things like a statin medication to bring cholesterol down.
So statin, the cholesterol medicines.
Yeah.
Amy, anything you want to add to that?
I think that was a wonderful summary of the things that we do to help with stroke prevention. You know, obviously, once somebody has already had a stroke, sometimes the treatment may differ.
That's where I want you to go, if you will.
Yep, and you know, I know Dr. Vick is probably more of an expert in this than I am, but once somebody has had something like that, we do think about medications sometimes to help thin the blood out a little bit, whether it's aspirin or Plavix, depending on the situation. But a lot of times the part of the problem is that clots get formed because the blood tends to stick to each other. So helping that to be less likely to happen in the future can decrease your risk over time.
That is correct. That's very good summarization of prevention of stroke in the very first place, which is the best cure, really. And then how do we go about tackling specific kinds of strokes? And in this case, you're right, we can give blood thinning medication like warfarin, but in the past few years, we also have some medications that are called NOACs, or novel anticoagulant medications. And these are the medications that can be substituted for warfarin for certain conditions.
Those are the ones we see advertised on television?
Yes, we see that, and this is not an endorsement of any product, but just to rattle off a few names, we have seen ads on TV like Pradaxa, Eliquis, Xarelto. So these are the medications that can be used specifically for conditions in which patients have atrial fibrillation. So this
what's atrial fibrillation?
So this is an abnormal rhythm.
Amy, why don't you tell us
sure.
what that is?
Yep, absolutely. So one thing that's fascinating to me about strokes is that they sometimes have different causes. So sometimes a stroke can have a cause similar to a heart attack, where you get maybe a plaque buildup or kind of an imperfection on the inside of a blood vessel. And then it ruptures, and when it ruptures, all the blood kind of tends to stick to it and gets to be more clotted. However, other things can cause strokes as well. And one of the things that we commonly think about doing that is something called atrial fibrillation. That's when the heart is beating in a fashion that's not coordinated. And because it's not beating in a coordinated fashion, blood tends to pool in the heart and stick to each other and clot. And then when it's doing that, the clot can travel from the heart up to the brain. And that's where we definitely see complications associated with atrial fibrillation, like potentially stroke.
Rachel, are there other things that can contribute? I guess we've already talked about the cholesterol and the rest, the atrial fibrillation. In your experience with the blood thinners, there's also, Dr. Vick talked a little bit about the different types of stroke earlier. So if I'm taking warfarin and I have a bleed and not a clot, then what?
Yeah, things can get really complicated when we start adding in medications to thin blood if it's too thick. And one of the biggest things that we see, the biggest side effect is bleeding. So then depending on the reason that you're on the blood thinner and how serious the bleed is and what it's from, it can be a conversation between the patient and the provider about what your risks are going off of a blood thinner versus staying on it, and it can be an individualized decision at that time. There's not always a 100% right answer in a situation like that.
So there's another thing. I'm an old farmer and I'm out somewhere in Wisconsin or wherever where I came from.
Yeah.
But say Willow River and the truck pulls up. Why wouldn't I want to go to the truck and have them check me out for atrial fibrillation and look at my carotids and all of that stuff?
Yeah. So many times patients will tell me that they get a mailing or that there's a truck somewhere offering a number of screening items for, say, $75, $150, something like that. And they want to know whether that's a good idea. And screening in a generalized population for certain conditions is a good idea. The first one that I told you about was high blood pressure. 100%.
What's high blood pressure?
Hypertension. So blood pressure.
What's your numbers?
Greater than 140/90. Although there have been a couple of really good studies recently that have shown that bringing that a little bit lower, 130/80, really can benefit in strokes and heart attacks. So we're trying to push people lower.
Yeah, totally.
The SPRINT trial was the trial recently that seemed to show that. However, there's a lot of other screening tools that sort of haven't worked out, but they're still being offered at times. So for a general population that doesn't have specific other medical conditions, things like carotid artery ultrasounds on everybody don't show to save lives, and actually at times can put people through extra procedures and studies that they may not need. There are other things that we do in office at sort of an annual exam that really are evidence-based and proven and that you should do. So I usually encourage my patients to talk to me in office, and if there's things that we should be doing, that I'll do them in office with them.
So Amy, let's go way back right out to the beginning, and I know that your practice is a little different than this, but how do I know I'm having a stroke? say I get a headache, or
Yeah.
what are the things? Isn't there a mnemonic that's used or something? That
I think I'm blanking on the mnemonic.
Fast.
it's fast. That's it.
Fast.
Oh.
Fast.
Act
Anyway,
fast.
You know, I think the things that I always think about with stroke are problems speaking, or if you have new weakness in one part of your body or another. New neurologic symptoms are particularly concerning to me when I see patients. Other
Sure.
advice?
Yeah, the acronym or the mnemonic we were talking about is FAST, and the F, as you rightly pointed out, it stands for facial droop. A stands for arm, which means like if you have weakness on one side of your body, and then S is for speech, like if you have slurred speech, and T is the most important, time. Act fast. If you have these symptoms, rush to the nearest ER, call 911. Do not sit on it, because with every minute you waste, your brain cells are dying, and that's what, I mean, if you give treatment fast enough, you can salvage those number of brain cells.
I think that's such a good point. I definitely have seen patients in my career that aren't aware that it's almost the same thing as a heart attack. I know everybody
Yes.
knows when you get a heart attack, you call 911, you go the ambulance into the hospital, but I think people are just starting to realize that a stroke is a lot of times the same sort of urgency, the same sort of emergency.
That is correct, and it is by increasing stroke awareness through programs like this and reaching out to more and more people that we make them aware and cognizant of these symptoms, and people are able to get treatment faster. So in fact, stroke is not even one of the top 3 killers in the United States anymore. It has dropped down the rung, which
4.5 hours.
is, yes,
So if you're in international falls, get moving.
get moving.
Anyway.
And it doesn't even have to be as I pointed out, like it could be much longer, and you may not be eligible to get the clot busting medication, but you can still get the clot removed.
Clot removal.
Yes, yes.
Amy, I think I'll throw this one your way. Let's talk about pregnancy and stroke. Or Rachel, whichever one of you want to jump in.
Well, I can say that during pregnancy, a lot of things happen to the body. The body does change a lot as you're pregnant, and people can be more likely to have strokes when they're pregnant, although it's not necessarily one of the most common things that I think of. How about you? Do you see the same kinds of things in your practice?
Yeah, I would say just the important thing to remember is pregnancy is a time when you're just more likely to form a clot. And that is one of the basic mechanisms of a stroke. And so
Yes.
during that time frame, you just have a higher likelihood.
Yeah, and interestingly, though, majority of the strokes during pregnancy, if they do happen, are still the normal variety of strokes, like the arterial strokes. But there is also a peculiar kind of stroke called the venous stroke, in which the clot is not on the arterial side. It's not in the blood vessel that's supplying blood, but it actually develops in the blood vessel that is taking away the blood from the brain, and that causes pooling of the blood in the brain, and that leads to stroke-like symptoms. And these strokes can present with headache. So more often than not, the patients will complain only of immense headache, and sometimes they can have seizures. So in this case, we would not get the usual stroke symptoms of weakness on one side of the body or slurred speech, but you might have different subset of symptoms. But nonetheless, awareness is important about these conditions too, and then we can take care of these patients as well.
So you can do something with that also.
Yes, definitely.
I should mention that while I don't classically think of headache as a big ischemic stroke symptom, there are certainly conditions that headache is a hallmark of
Yes.
things that need to go to the doctor's office. I'm sure Dr. Jadhav and Dr.
So just
Gordon
carry
can
that
talk
right
about
on to
that more.
aneurysms, why don't you?
There are things called aneurysms, and when they rupture, a lot of times one of the classic descriptions is a patient comes in complaining of sudden onset of the worst headache that they've ever had in their life. And if that ever happens to anybody, that's not something that you try to wait out. That is something that you seek medical attention for, because it's important to get those things treated in a timely fashion.
Are they hereditary?
There could be, there are some factors that are linking to genetic linkages, so there are hereditary. So if somebody has a first degree relative who has already had aneurysm ruptures, and if they have a certain size of aneurysm compared to another one who absolutely has no history, in those cases, we do an individualized case-by-case basis, like risk assessment, and then treat the patients accordingly. So they are, and another big factor is smoking for aneurysms. We always caution the patients, do not smoke.
Let's talk about falling and hitting your head. This person fell and had a brain bleed, and then experienced short-term memory problems after that. Is that from the fall, and what can she do to help improve that? Is there anything that...
I think, you know, it's always hard to say why things end up happening, but, you know, do we sometimes see people that have memory issues and residual problems after they have a fall that results in brain bleed? Certainly we do. I guess the best advice that I would have for my patients when they have evidence that there's something that's continuing to go on is to stay as active as they can, to work as hard in rehab as they can, and even to stay mentally active as well. The brain is an amazing organ. It can suffer insults, and it can figure out different pathways to rewire and to handle things differently. And the more we exercise that, the more our brains are able to adapt.
This is an interesting, I'm going through questions a little bit now. I'll change the topic just a little bit. This lady's had a stroke. She's on Plavix, Lipitor, baby aspirin, needs dental work. The dentist says it's too dangerous to do dental work. And I'm looking for the wisdom of the three of you in this situation.
I'm sure you see patients like this in your practice all the time.
Yeah. So both aspirin and Plavix are blood thinners and can increase your risk of bleeding. Depending on the type of dental work and when the insult happened, so when the stroke happened or when a stent was placed or when those medications were started, a lot of the times we'll talk about the ability to either hold them for a certain period of time for a procedure, or that there are other ways to try and control the bleeding during a procedure. So for a lot of superficial dental work, you could go ahead and have things done, both on aspirin and Plavix, just fine. There are some surgeries that are done on both of those. If there was really invasive surgery where there was a really high risk of bleeding, then depending on when the